When thermal energy strikes the skin, it begins a physiological countdown. A localized injury triggers a sequence of events that extends far beyond the point of contact. At the cellular level, a severe burn acts as a massive whole-body inflammatory insult. The immediate aftermath can be deceptively calm. A patient with a significant burn may appear completely stable and lucid in the minutes following the injury. But that stability is temporary. Inflammatory triggers are already circulating through the bloodstream, and without intervention, the patient may rapidly deteriorate. Over the coming hours, survival depends on a race to identify internal damage that has not fully manifested yet. This requires a meticulous, multi-layered assessment to intercept a potentially fatal systemic cascade. This physiological collapse unfolds over a strict 24-hour timeline. Survival depends on the clinical team's ability to manage this critical window. Clinicians manage this crisis through 3 anticipatory protocols: preemptive airway control, strict mathematical fluid resuscitation, and mechanical tissue release. While the standard ABCDE trauma framework applies, it must be adapted to the specific time-dependent physiological cascades of a major burn. Success depends on preempting physiological failure before it manifests anatomically or hemodynamically. The first clinical priority occurs between the 0 and 4-hour mark. The evaluation begins with the protective barrier, the skin, but the most immediate threats to survival often exist beneath the surface, beginning with inhalational injury and its effect on the respiratory system. Breathing, securing the airway. Thermal and chemical irritation cause progressive mucosal edema. This swelling steadily reduces the airway lumen diameter. It usually reaches its peak between 4 and 24 hours after injury. This threat is most acute after inhalation of smoke or hot gases, especially when a patient has been trapped in an enclosed space. Indicators of inhalational injury include loss of nasal hairs, visible burns on the nasal mucosa or hard palate, voice changes, and the onset of stridor. Delaying intervention until the patient shows respiratory distress is dangerous. By the time stridor is audible, the anatomical structures may already be too distorted for standard intubation. Secure the airway early. Elective intubation ensures that the tube is placed while the anatomy is still recognizable, before predictable swelling makes the procedure difficult or impossible. While the lungs struggle, the cardiovascular system faces its own crisis. Burn shock. Burn shock is a failure of containment. Inflammatory signals cause a massive increase in capillary permeability. The vessel walls effectively become porous, allowing water and proteins to leak out of the bloodstream and flood the surrounding tissues. This creates a dual catastrophe. The tissues swell with leaked fluid, while the effective circulating blood volume drops dramatically. This is the physiological collapse that TBSA measurement is designed to predict. It starts with calculating the scale of injury, the total body surface area, or TBSA, involved in the burn. This anatomical map illustrates the rule of nines. It is the fastest tool for bedside estimation in adults. The head and neck represent 9%, each arm is 9%, the front and back of the trunk are 18% each, and each leg is 18%. Because children have different body proportions, clinicians use the Lund and Browder chart for greater precision. This model adjusts the percentage assigned to each body region. In children, the head accounts for a larger percentage, while the limbs account for a smaller percentage. For small or patchy burns, the patient's own hand can be used as a measuring tool. The entire hand, including the palm and fingers, represents roughly 1% of the patient's total body surface area. Calculating TBSA provides the baseline data needed to predict the intensity of the patient's systemic response. Intravenous fluid resuscitation is required for adults with burns involving more than 15% of their total body surface area, and for children with burns involving more than 10%. The Parkland formula multiplies 4 milliliters by the burn percentage and the patient's weight in kilograms. A 70-kilogram adult with a 20% burn requires 5,600 milliliters of fluid. This volume is split evenly. The first 2,800 milliliters are infused within the first 8 hours. The 8-hour clock begins at the moment of injury, not at the moment of hospital arrival. Clinicians must subtract any pre-hospital transit time from this first infusion window. The remaining 2,800 milliliters are distributed evenly over the following 16 hours. Replacing intravascular volume must outpace capillary leakage to maintain organ perfusion. Fluid requirements and monitoring strategies change between the 8 and 24-hour marks. Crystalloids, such as lactated Ringer solution, are the first-line choice. Colloids, such as albumin, are usually introduced only after the initial 12-hour window. During the first 12 hours, widened capillary gaps allow large proteins to escape into the tissues. Giving colloids too early can pull more water out of the bloodstream, worsening edema. After 12 hours, the capillary beds begin to stabilize. Colloids can then remain within the vessels, using oncotic pressure to draw fluid back into the circulation. While the Parkland formula provides an estimate, real-time bedside monitoring determines the actual fluid rate. Urine output is the key clinical marker of end organ perfusion. The infusion rate is titrated to maintain a urine output of 0.5 to 1.0 milliliters per kilogram per hour. Low urine output indicates hypoperfusion and requires an increase in the infusion rate or a fluid bolus. Excessive urine output suggests fluid overload. In this case, the infusion rate is slowed to prevent worsening edema. High-voltage electrical burns are the exception. These injuries release myoglobin into the blood, requiring a higher urine output target of 2 milliliters per kilogram per hour to help prevent renal failure. Titrating fluid against real-time renal output determines the final volume required for survival. Beyond the initial Parkland estimate, aggressive fluid resuscitation increases underlying tissue swelling, creating mechanical threats in the extremities and chest. Circumferential burns create an inflexible band of dead tissue called an eschar. It acts like a biological tourniquet. It restricts the swelling tissue beneath it, threatening distal limb perfusion and preventing the chest wall from expanding during ventilation. Clinicians use escharotomy, which involves surgical incisions through the burned tissue to release this mechanical pressure. These release lines follow the mid-axial pathways of the limbs. Precise placement is vital at the elbow. The incision must avoid the medial aspect to protect the ulnar nerve from surgical damage. Decompressing these tissues ensures that successfully resuscitated blood can actually reach the extremities, and that the lungs can expand properly. The assessment now moves from surface area to tissue depth, using 3 specific markers: moisture, capillary blanching, and sensation. A superficial partial thickness burn appears pink and moist. The tissue blanches white under pressure before color quickly returns, and the area remains painful. Deep partial thickness burns are drier and lose reactive capillary blanching. At this depth, the patient's sensation is noticeably reduced. Full thickness burns present a paradox. The tissue may appear hard or leathery, but the injury is often painless. This cross-section shows why. The heat has penetrated through every layer of the skin, charred the tissue, and destroyed the nerve endings. Because the biological structures needed for repair are gone, these burns cannot heal on their own. Care in the first 24 hours is defined by the intersection of airway management, fluid resuscitation, and mechanical decompression. Secure the airway before anatomical distortion occurs between 4 and 24 hours. Calculate fluid needs from the moment of injury, then titrate the infusion based on hourly renal output. Release circumferential constriction to preserve limb perfusion and ventilatory capacity. 3 variables dictate the outcome: the percentage of total body surface area involved, the depth of tissue damage, and the presence of inhalational injury. These threats must be managed simultaneously. Failure to stabilize the airway or replace the leaking fluids can accelerate the collapse of every other system. Success in burn medicine is found in the ability to read the surface of a wound and anticipate the systemic storm beneath it. It is the science of stopping total collapse before it even begins.
If you like this video, give us a thumbs up.